It gives me great pleasure to introduce our second speaker now, Professor Craig Meyers, Distinguished Professor of Microbiology and Immunology from Penn State University College of Medicine. Professor Meyers has achieved national and international renown for his work on human papillomaviruses. He has published over 100 studies covering a wide range of areas including HPV replication and oncogenesis, viral structure, immune protection, and describing the role of HIV and anti-HIV drugs on HPV-associated cancer.
Thank you, John. Today we're going to talk about breaking ground in HPV disinfection, reducing HPV transmission risk from ultrasound procedures. My name is Dr. Craig Meyers. I am a distinguished professor in microbiology and immunology at Penn State University. So first, our learning objectives. The first objective is to understand the risks and dangers of HPV infection. Second, describe the evidence for the risk of HPV transmission from ultrasound probes. Third, understand the efficacy of hospital disinfectants against HPV. And fourth, describe the regulatory criteria to claim efficacy against HPV. Why are we talking about HPV? Well, I've been working on HPV for over 30 years, and we know a lot about how HPV causes cancer. But we haven't, until recently, been able to produce large amounts of HPV in the laboratory. We've recently, in the last few years, developed a technique to grow natural infectious HPV virus. We tested the virus against many common disinfectants, and we were surprised that our results showed that many disinfectants were not effective at deactivating or killing HPV. Today, you will be given recommendations on what you should do to mitigate HPV transmission from ultrasound probes. So we all know that HPV is a clinically important virus. HPV can cause cancer in both sexes. It causes almost all of the cervical cancer cases seen in the world. It can also cause anal cancer, penile cancer, vulvar cancer, vaginal cancer, and oropharyngeal cancers. Probes come in contact with the common HPV cancer sites, or in other words, the common sites that can be infected by HPV. So intercavity ultrasound is associated with the highest cancer risk regions. And you can see here the examples of the probes for the esophageal area, the cervix or the vaginal canal, and for the anal canal sites of the body. Now, there's a difference between high-risk and low-risk HPV. 25% of people are infected with some type of HPV, but only less than 5% are infected with a high-risk HPV. And what we mean by high-risk, those are the HPV types that can cause cancer in humans. High-risk HPV can cause cervical cancer, and HPV 16 and 18 cause about 70% of all cervical cancers in the world. People with an HPV 16 infection are 700 times more likely to develop cervical cancer. Now, it's generally thought of that HPV is a sexually transmitted virus, and this is definitely true. But one thing we don't talk about much is that HPV can also be transmitted non-sexually. So there's a growing recognition that we also have to be concerned with this non-sexual transmission. And this can be done by self-inoculation, by inanimate objects, and by the environment. And you can see here we list three publications of several that you can find in the literature that talk about how HPV can be a non-sexually transmitted. So the potential for HPV transmission from probes. Well, first off, we have to look at some of these other risks, for non-sexual transmission. The first is that children have contracted HPV without sexual activity. You can find HPV on the fingertips of infected individuals. In fact, 20% of people who have anal genital HPV infections at any one time will have the virus on their fingertips. The other thing is there can be poor compliance with cleaning and disinfection. HPV can also be found on the probes after reprocessing. And HPV is highly resistant to disinfectants. HPV remains infectious in a typical dry room environment for many days. So the sonography environment is also contaminated with HPV. And here's a little, this is an article where they went in and they looked at the different areas of a gynecological exam room, and they showed that HPV, even after proper disinfection, was still could be found on different areas in this office. As you can see here in colposcopes, over 43% of the colposcopes, after following the proper protocols for HPV disinfection, still had HPV on them. You can see that the glove boxes had HPV up to 10% of the time. The lamps in the room, over 37% of the time. And the ultrasound gel tube also had HPV contamination on it. So contact with mucosal surface creates a high potential for transmission risk. Proper storage of the ultrasound probes is important, that there's no airflow, that it's in a clean location, and that the probe storage has a cover. This will prevent recontamination of the probe from the environment. Now, you might have heard of a criteria called the Spaulding criteria, and this comes from the late 1950s. And this has been a globally adopted system to determine what type of disinfection levels should be used for a specific pathogen activity spectrum. And so you can see here on the left the classifications, and those are critical, semi-critical, and non-critical. And so the level of disinfection required for critical is complete sterilization. For semi-critical, it's high-level disinfection. And for non-critical classifications, a low-level disinfection. And the definition of these is that for critical or sterilization, all forms of microbial life need to be destroyed. In a semi-critical, where high-level disinfection is required, this needs to destroy all microorganisms except spores under normal use and spores at extended contact times. And then for non-critical or low-level disinfection, this does not need to destroy spores, mycobacterium, nor non-enveloped virus like HPV. So the question on each of these is, should it kill HPV? And critical and semi-critical, by their definition, should be able to kill HPV, where non-critical does not need to be able to. So to call your disinfection protocol high-level disinfection or sterilization, you must be able to kill HPV. So common liquid chemical disinfectants have not been tested against HPV until now. We decided to test the efficacy of these common liquid disinfectants or sterilants and low-level disinfectants against HPV. So we used for these tests a disinfectant suspension test, and prior to 2014, no disinfectant had ever been tested against native infectious HPV. And in these tests, we used HPV-16 and our liquid disinfectants. And you can see here on the left, we just mixed the disinfectant with the authentic infectious virus. We waited 45 minutes, and this exceeds the manufacturer recommended contact time. And then we tested for remaining active or remaining infectious virus after this 45-minute incubation. So here are the liquid disinfectants that we tested against HPV. You can see the GTA, OPA, ethanols and isopropanols, phenols, PAA silver, and hyperchlorite here on the left. And you can see their use. The GTA and the OPA are used for semi-critical medical devices, where all the rest of these disinfectants are used for non-critical environmental surface or hand rubs in the case of the ethanol and the isopropanol. So which one of these are suitable for probes? Well, of course, the GTA and OPA, because these are to be used for semi-critical medical devices. So they represent the class of disinfectants that we call high-level disinfectants. And so by definition, they should be able to kill HPV. So here's a graph of our results. And what it shows, I'll give you the punchline right off, is that some hospital disinfectants do not kill HPV. On the left, you can see this is a log 10 reduction of native HPV. The dotted line is a 4 log reduction, which is mandated by the FDA as the minimum efficacy for high-level disinfectants. So every point above the 0 line is a 10-fold decrease in infectious HPV. Now, you can see right off here that most of these disinfectants were inadequate, had no efficacy to deactivate or kill HPV virus. The only things that were able to induce a 4 log decrease in HPV infectivity were the 1.2%, the high percentage PA silver, and the hyperchlorite or the bleach. And I need to point out that 1.2% PA silver is not FDA approved, so it's not something that can be used in a hospital setting at this time. What can be used is the 0.25% PA silver, which we show here does not deactivate HPV at all. But what's more important is there in the middle, where you look at GTA and OPA, which are considered hospital sterilants. They're considered high-level disinfectants, and what a lot of people use to disinfect their endocavitary probes. And neither one of these, both the GTA at 2 concentrations and the OPA at 0.5%, neither were able to deactivate HPV at all. So we decided, well, maybe 45 minutes is not long enough. So we tried extended contact times. And high-level disinfectants should be sterilants, kill everything at extended contact times under regulatory requirements. So we used the 3.4% GTA and the 0.55% OPA, which, according to the manufacturer, should have a contact time of 45 minutes and 12 minutes, respectively, to be a high-level disinfectant. And what we showed was at 45 minutes, neither was able to kill HPV. So what about 24 hours or 48 hours? So we tested the GTA for 24 and 48 hours and the OPA for 24-hour contact times. And in all these situations, there was no significant killing of HPV. There wasn't even close to a 1 log reduction of HPV with these long contact times. Then, with this result, we showed that none of these common disinfectants were able to kill HPV, even ones that have been called high-level disinfectants. So we decided to test an automated high-level disinfectant system against HPV. And this system uses sonicated hydrogen peroxide. So there's no toxic byproducts. It has a short cycle time of 7 minutes. It includes both the probe and the handle. It gives you a computerized record. It has an internal indicator, and we found it to be HPV effective. So what we did to do this test was we used the carrier test, which represents more of the real-life circumstances. And this is the test that's actually required by the FDA. So we took these discs, and we actually put our virus on there and let it dry. And we have been able to show that after drying the virus on there, we can recover over 90% of our infectious virus. So we don't lose a lot of virus by the drying process. And then we can take that disc and we can treat it with the disinfectant. And you can see the comparison here of the carrier test on your left and the suspension test on your right. So here's results from our carrier test. And in these studies, we use both HPV-16 and HPV-18. And it's the same graph, similar graph as you've seen before, where this is a log 10 reduction of HPV-16 or HPV-18. The blue line show that these are our tests, and our clear boxes are our control samples. So those are just dried virus that we took off, we dried and recovered each time. And you can see that in all cases, using this automated device, both using 35% hydrogen peroxide and 31.5% hydrogen peroxide, we exceeded the 4-log reduction that's required by the FDA. And in the case of the 35% hydrogen peroxide, we were able, with both HPV-16 and HPV-18, have a complete inactivation of the virus. Now, our controls here were hyperchlorite, which is bleach, as you know, and that was our positive control to show that we do get killing. And we used OPA because we know that doesn't work from our other studies. And again, we can see here that it does not kill HPV-16 or HPV-18. So this graph is just to kind of show you the escalating risk in ultrasound probe reprocessing. And also to point out, there is now a solution to mitigate or remove this risk. HPV DNA is found on probes and probe sheaths after use. HPV DNA remains on the probe after cleaning. We have shown that high-level disinfectants like GTA and OPA that are considered sterilants that should by definition kill HPV actually are HPV ineffective. They do absolutely nothing to deactivate HPV. HPV remains infectious for several days on a surface, such as a probe, and the probe is reused. HPV transmission occurs with skin and mucous membranes, contact. And so if HPV is not killed on the probe by the disinfection protocol, that means there's a risk for the next patient that the probe will come in contact with, that the virus can be passed to that patient. So what's the global responses so far to HPV results? Well, so far the responses have come from the USA and France. So some regulatory authorities are taking notice. So in the U.S., the response has been that GTA and OPA are accepted as high-level disinfectants for ultrasound probes. However, OPA and GTA, as you've seen, are ineffective against deactivating or killing HPV. The FDA and the CDC are both aware of the situation, but they have not yet made any recommendations. The CDC has sought funding to do further research in collaboration with the University of North Carolina. Basically, they want to corroborate what I have done in my lab. So in France, this data was presented in June at Nantes, and this is the French SF2H conference. This is their big infection control conference for their country. Currently, French guidelines advise that upon inspection of the sheath and probe, if there are no tears or no soiling, that low-level disinfectant is acceptable for reprocessing intracavity ultrasound probes. The Ministry of Health in France is monitoring guidelines, and HPV is an important issue that they're considering. And I've been in communications with them since June on helping them to work through these guidelines. And this is over here on the right is a statement that was given by recently by their government. With regards to HPV, this analysis shows heterogeneity in the efficacy of physical and chemical intermediary level disinfection techniques. Systematic performance of an intermediate level disinfection equivalent to the USA high level disinfection between each patient is likely to prevent the spread of contaminants associated with biological fluids during intercavity ultrasound examinations. So what can sonography professionals do to protect their patient? Well, you can first reduce the transmission of HPV via the hands. We know that alcohols, these do not kill HPV. You know, and alcohols are in all our hand gels and in our environmental disinfectants. They're still good at killing bacteria and envelope viruses, but they do not kill on-envelope viruses such as HPV. So the recommendations we would give you today is to use gloves, of course, Gloves are the best for all pathogens as long as they are changed frequently. And that means, between patient examinations, before handling reprocessed probes. Take care not to contaminate your hands when removing the gloves. And then finally, it's the good old hand washing. May be better than the hand gels because the physical removal and washing away of materials on the skin. So reducing transmission risk from surfaces and probes. Well, hypochlorite or bleach kills HPV. We know that. It can be used and is used on environmental surfaces. So the recommendations are to consider intermittent surface cleaning with hypochlorite once a week. Physical cleaning can help remove microorganisms. For ultrasound probes, the automated hydrogen peroxide device we know, and so far it's the only thing we know that can kill HPV. So the recommendations here are consider using an HPV effective ultrasound probe disinfection product, and this is very important for intercavity probes. So reducing transmission risk via probe storage. So, this is also important. So the recommendations would be store the reprocessed probes in such a way to prevent recontamination from the environment. Handle reprocessed probes carefully to avoid cross-contamination and handle with fresh, clean gloves only. Make sure the probe is thoroughly dry after reprocessing, and store away from airflow, heat, humidity, and moisture. Consider using storage covers, but make sure the probe is dry first before you put it into the storage. So selecting a disinfectant product. Well, recommendations. You need to carefully review the justification for all efficacy claims. High-level disinfectants, by definition, should be effective against HPV. But we have found that some high-level disinfectants are not effective against HPV. There are no recognized surrogate viruses for HPV in the USA. HPV must be tested directly if you are to say that your disinfectant is effective against killing it. To establish efficacy, the FDA requires the use of large amounts of HPV virus in standardized tests to represent the worst-case scenarios. And so I want to stop there and thank you for listening, and we'll take questions, I'm sure. And I just have to show you, these are the people in red here that work in my lab and have done all the work so far in demonstrating the efficacy of different disinfectants and their ability to kill HPV. And thank you for your time.
Thank you, Craig. So just want to go to some questions now. We've got quite a few questions coming in. So the first question here is for Bob, and the question reads, should all probes have covers? Is that what the Joint Commission is looking for? Bob?
No, just probes that will be used in procedures or in intercavitary types of procedures, or if the patient has some sort of contact isolation, sometimes we will use them to keep the viruses and bacteria off the transducer, especially if we're doing portables and we aren't able to do a high-level disinfection between patients.
Thank you, Bob. So next question is for Craig. What is the effect of the HPV vaccine? Does this protect people from infection?
Yes, the vaccine is very efficacious. The biggest problem, though, right now is in countries such as the USA, only about a third of the people that should be vaccinated have been vaccinated, or at least a third of the women that should be vaccinated, and probably less than 10% of the men in the U.S. So we are not getting the coverage that we need to make the vaccine protective in our society. So until that happens, we will still have a problem of potential spread of HPV. You turn to other countries such as France and Germany, your rates are dropping below 20%. And recently, the word I've heard is that in Japan, they've canceled the vaccine program altogether. So right now, the vaccine has the potential to really protect us against HPV. But like any vaccine, if people don't take it, then it's worthless.
Great, thank you, Craig. So we've got another question here on hydrogen peroxide wipes. So do you know if we can use an H2O2 wipe on the probe surface and intracavity? So I might take this one. So there are wipe products available in the US that are low-level disinfectants and intermediate-level disinfectants, and they could potentially be used on a surface probe so long as the probe manufacturer IFU says that it's okay, because sometimes the chemistry could interact with the plastic, so you need to check that. For high-level disinfection in the US, there are no wipes or sprays approved by the FDA. So basically, soaking solutions and the automated product are available for high-level disinfection. So, Craig, a question for you. Are there any documented cases of HPV from an ultrasound transducer in the USA currently?
No, this is probably going to be a very difficult thing to actually prove, because unlike some other infectious agents where within 24, 48 hours you're going to have symptoms of, being infected with that agent, HPV can take literally years, if not decades, before any symptoms appear. So the ability to trace it back to a source will be very difficult because of the long time period before you're going to see any symptoms. And so the problem with this is that there are thousands of cases in the United States where women are actually suing or blaming their OBGYN or the hospital visit for infecting them with HPV because they know that this is the only way they could have got the virus. But so far it's been impossible to prove that that any hospital source has infected you, just because of the timeline between infection and showing symptoms.
Thank you, Craig. Look, we're running out of time, but I'd just like to ask a couple more questions. This one's to you, Bob. Should you use HLD on each probe after each patient?
That's my belief. Again, we try to do high-level disinfection on every transducer between every patient. Now, obviously, it's not always possible, especially in a portable setting. But when the patients are in the department, there's plenty of time between patients to put the transducer in the trophon. It's a 7-minute process, doing your paperwork, checking the history of the patient, looking at old or other imaging modalities. So we do try to do that to protect our patients. Okay. When portables, we try to, again, make sure we take the proper disinfection material with us as we go from room to room.
Sure, Bob. And another question. What is the best way to store the probes between exams?
Well, if you have a wall rack, we were told we had to enclose it, so our carpentry shop actually built like a cabinet around it. We keep them in drawers with plastic covers on them that are marked clean. There are cabinets out there being made now. Transesophageal and endoscopic probes have these big cabinets, so these smaller versions are now being created to store ultrasound transducers in. So anything that just keeps it out from being out in the open.
Thank you very much. The question reads, the last time I checked, most of the surface probes were not approved for high-level disinfection. Are there methods available now to HLD the surface probes?
Well, yes, if you take a look at the manufacturers, they'll tell you the different things you can use on the transducers, and some of those will be high-level disinfection. Again, to me, when you really start to read about things like VRE and MRSA and C. diff and how it gets spread, but more importantly, how long they live on surfaces, and we're talking weeks to months, it sort of makes you want to make sure you're really cleaning those transducers. So, again, at our institution, we try to do high-level disinfection on every transducer when possible. But again, you don't really need, there's really nothing that says you have to. That's something that hopefully as we learn more and more about these different bugs and viruses and how they're on our transducers and how we're not really doing a good job with these wipes to get them off, that maybe we'll be requiring more and more high-level disinfection on all of the transducers all the time and not just on procedures and intercavitary transducers.
Thanks, Bob. And I think this will be the final question. So, Craig, someone here has asked, do you think glutathione and OPA will continue to be used?
Yes, until the government readdress their protocols that they require people to use. I think people will, continually to use those because they will be following what the government tells them they need to do.